You are listening to the global network of podcasters dedicated to the pharmacy profession. Welcome to the Pharmacy Podcast Network.
Welcome to the PBM Reform Podcast, where we dive deep into the world of pharmaceutical benefit management, cutting through the noise to uncover the truth. Since 2019, we've been your go-to source for the latest on how PBMs impact patient care, drug pricing, and the very future of pharmacy. Here, we champion the role of pharmacists, the most knowledgeable advocates for medication safety and expertise. Join us as we expose and generate discussions that are reshaping healthcare and explore how we build a better payment system which focuses on advancing pharmacy care.
Hey, welcome back to the PBM Reform Podcast. This is in support. We're getting amazing support from APCI, the United Voice of Independent Pharmacy. Just to learn more about the American Pharmacy Cooperative Incorporated, go to apcinet.com. Once again, that's apcinet.com. And our host is back, Greg Reybold. Greg, it's so good to see you. It's so good to talk with you. I love the insights that you bring to our listeners on the Pharmacy Podcast Network about PBM reform. And it couldn't be a hotter, boiling tub of water right now in PBM reform for our nation. So, Greg, take it away.
Yeah, that's right. And appreciate it, Todd, as always. Super excited about today's guest and today's conversation. And this is one where, you know, if he's good enough, we haven't even started talking yet. And I'm already telling him I want him back, right? Because there's so much to talk about. And so we have Conor Sheehey from Levitt Partners joining us today. And, you know, it's always interesting what shapes the practice of pharmacy. And behind me, this podcast, so y'all probably can't see it, but I've got an old pin from it's probably the 90s. And it says, get into politics or get out of pharmacy. But there's so many things that shape the practice of pharmacy at state levels, at federal levels. And this is a really unique opportunity for pharmacists and others to hear from, I think, really one of the brightest minds in pharmacy and who shaped pharmacy policy, but who, you know, pharmacists behind the counter, you know, on Main Street America may not yet know. And so really excited to have you, Conor, and would love for you to just, you know, spend a minute or two just kind of introducing yourself and giving a little background.
Thanks so much, Greg. It is always great to connect with you. Thrilled to have the opportunity to participate in the podcast this morning. I am a longtime listener, first-time guest. So again, really appreciate the opportunity. I should start by saying at the outset, as was noted in the intro, I currently work for Levitt Partners. I'm here speaking in my personal capacity, not on behalf of the firm or our clients.
Absolutely.
But I can also say, virtually whoever you talk to across the healthcare sector is plugged into PBM reform as an issue and is energized about achieving solutions on this front. And I first came into this space when I started on Capitol Hill back in 2017, so roughly 8 years ago, when I worked for Senator Tim Scott of South Carolina, who served on two of the leading healthcare committees in the Senate. And I will say, this was still a time where you didn't have a lot of TV commercials talking about pharmacy benefit managers or PBMs. I came to Capitol Hill with very little knowledge about what PBMs did, what their function in the supply chain was. I remember looking at flow charts of the prescription drug supply chain and feeling totally intimidated. And I questioned many times whether I had made the wrong choice by stepping into healthcare policy in particular, just given how daunting it can be. And Greg, I think, you know, the APCI connection is so important because for most of us, including for me when I first came to Capitol Hill, my primary touch point with respect to prescription drugs was the pharmacy. And the goal of the pharmacy in many ways was, with respect to the consumer, to ensure you didn't have to think about the broader supply chain, and you didn't have to think about the drug channel, and you pay an affordable cost, you know you were getting a reliable product, you'd have a friendly rapport with your pharmacist, and then you go about your day. But over the course of my time, right? So exactly, and over the course of my time in Senator Scott's office, I had the privilege to start delving into these issues a little bit more. But then in 2021, I moved over to the Senate Finance Committee. And just because Senate jurisdiction issues are only known to people in Washington, D.C. proper, generally, because they're so arcane and they're almost as convoluted as the prescription drug flowcharts, which is saying something. We set and exceed that high bar. But the Senate Finance Committee has jurisdiction over the Medicare program, as well as Medicaid, the Children's Health Insurance Program, and a lot of health tax-related policies, such as health savings accounts. So I had the privilege for 4 years on the Senate Finance Committee, working under now Chairman Mike Crapo from Idaho, where you talk about a state where community pharmacies are a lifeline. You've got a state like Idaho with such sweepingly large rural communities and rural populations. I mean, those folks really care about and value those pharmacists and pharmacy relationships. Again, that's often their frontline access point to healthcare, and it's the only alternative to driving, 1, 2, 3 hours, sometimes out of state, to reach a frontline provider. But I think because Senator Crapo had that perspective, and because he's always cared a lot about healthcare access, affordability across rural, urban, suburban communities, we were able, really as a team and on a bipartisan basis within the Senate Finance Committee, to undertake what I think is fair to say is the most comprehensive federal pharmacy benefit manager reform effort to date. And this involved efforts from members across our committee who were from diverse states representing communities from all walks of life, but in partnership with then Chairman, now Ranking Member Ron Wyden of Oregon, and for my part, in partnership with my counterpart, Polly Webster, who was just phenomenal and equally plugged into these issues, we were able to develop bipartisan legislation over the course of 2 different bills, which we moved through our committee the first time around near unanimously, the second time unanimously. And I think what was crucial for us was we had policies aimed at getting at some of the supply chain incentives, but we also had provisions aimed specifically at ensuring pharmacy access protections for Americans, for seniors, for folks in Medicaid, and for, again, folks from any different commercial insured market, you name it, recognizing that Congress has had a longstanding commitment to serving the needs of communities, including folks like those in Idaho, where those frontline pharmacies are their key access point for healthcare. And that commitment is reflected in the letter of the law. When you look at something like Medicare's prescription drug benefit, on paper, there's this any willing pharmacy provision, but I think in practice, and Greg, we'll get into this more, despite being a former Senate staffer, I don't want to start this discussion off by filibustering. But I will say, I think for Polly and me and for Senator Crapo and Senator Wyden and for so many of our members, it was crucial that we had protections for patient affordability, that we had provisions that got at the heart of some of the faulty, distorted incentives within the supply chain, and it was crucial that we shored up those pharmacy protections with clarity, with enforcement, and with oversight. And I will stop there.
No, look, that's great. And there, again, we could probably riff just off what you said for a really long time. But you just touched on something that I always find fascinating to talk about. And you mentioned like any willing provider, right? And so much of what we see in the regs, and we're just jumping right into deep water here. But when you read federal code and then you look at sort of the way it's played out in practice, it's fascinating, right? Because if you read that federal code and it says, hey, any willing provider, boy, you think case closed, right? Patients are going to have access to the provider that is going to be of their choice. And then lo and behold, below the law, there's sort of this complex regulatory scheme where you've got preferred networks and narrow networks and specialty medications being filled predominantly at PBM-owned pharmacies. Something really similar that I always think of sort of hand in hand is rebates, right? Because federal law also says that beneficiaries are going to be offered the negotiated price, and federal law includes within negotiated price discounts, DIR, rebates, and what we see in practice. And when you were in your position in Senate Finance, we talked about this, I think at least a few times. But what we see in practice is, I think there was a MedPAC report that looked at, I think it was the year was 2021. They found $50 billion in drug manufacturer rebates that were treated as DIR, meaning beneficiary cost shares, beneficiary copays, being based on sort of this gross price instead of the price net of the rebates and the discounts that federal law contemplates. And you and Polly both, I think, really delved into the weeds and sort of tried to get it. Well, why is practice not matching necessarily what federal law says, and how does that happen through the regulatory process, and shows you how important regulations are. Would love for you to just expand on that a bit.
Yeah, Greg, I'm so glad you brought this up, because this was a key area of prioritization for a bipartisan crew of our members. And I think there was a real red flag across Capitol Hill in September 2023 when the Government Accountability Office, or GAO, they released, I thought, a pretty barn burner of a report that had looked at scores of data and had looked at contracts between manufacturers and PBMs, all in the Medicare Part D space. And I remember the top line finding, and there was a nifty infographic showing this, suggested that for 79 of the 100 most highly rebated drugs, so these are products where the manufacturers were paying discounts, in some cases of 50, 60, 70, or we know from the insulin example, in some cases 80 or 85 or 90%. You would think for beneficiaries, that's the best case scenario, because they're going to get these massive discounts passed through. And that's part of the reason you enroll in a health plan. That's why most folks want to be covered through insurance. And with a program like Medicare, that's why people work their entire lives and pay into this system with the expectation that when they turn 65 and they enroll in the Medicare program, that they're going to be protected from sticker shock, out-of-pocket costs. But for this GAO report showed that for 79 of the 100 most highly rebated drugs, the beneficiaries in a given year paid more than their plan sponsors did. In some cases, plan sponsors, so these are the carriers, and again, for most of the Part D market, these folks are affiliated with PBMs. And so they are, negotiating with their own subsidiaries at different levels. And they were, in some of these cases, essentially turning a profit off of these rebates, even as at the pharmacy counter, plans increasingly in recent years have exposed seniors to those list prices. And Greg, I think you were right to point this out. We often think about Medicare benefits and prescription drug benefits through this lens of what they might have looked like 10 years ago, 15 years ago, where I think what folks generally expect with their health insurance is, for the most part, you'll pay a flat copay. And that's true for most generic drugs, right? Most generic drugs, you go to the pharmacy counter, you're paying $5, $10, but we generally think of flat copays. And what we've seen over the course of the past few years, and I think it's fair to say there's a restructuring going on of Part D right now under the Inflation Reduction Act that passed a few years ago, that is changing that landscape such that more and more plans are turning to co-insurance, where you're paying a percentage of Greg, as you said, the negotiated price. And I just think it defies logic that the quote unquote negotiated price would not reflect any of the negotiations.
Yeah,
it doesn't reflect
discounts.
any of the discounts. And so to me, it's like if you have a product that has a list price of $1,000 and your health plan or PBM negotiated an 80% rebate, an 80% discount, that's fantastic. That's actually, again, there's a world in which that PBM could say, look at our value proposition and our value add to the system. Because again, I think consumers rightly want a buffer in some cases between, the list pricing power of a given manufacturer and what they're paying at the pharmacy counter. But in practice, those rebates are subject to, in most cases, really stringent confidentiality protections, non-disclosure agreements, all sorts of contractual protections. So as the consumer, I see that $1,000 and I'm like, this manufacturer is really screwing me over with this high price. And again, traditionally, maybe I'm paying a $20, $25 flat copay. In that case, I'm insulated. Right. More and more, I'm paying a 25% coinsurance, so I'm forking over $250. And in the example I gave, that's actually that's a profit on that unit for my plan, even as I'm $250 down. And the last thing I'd say is we see this across the commercial market too. Deductibles are getting bigger and bigger in the commercial insurance space and the Part D space. So that means in a given year, I may have to pay, in the Medicare context, $500. In the commercial context, often much more. Yeah. Before I even start getting any benefit from the plan with respect to a prescription. And in the deductible phase, I am always paying on that inflated sticker price.
That's right.
That
I'm
gross
so glad
price.
you brought that up.
Yeah. So I guess the last thing I'd say on this, Greg, I think what we tried to do with the Senate Finance Committee process was figure out, we know that these rebates by and large are being translated into buying down premiums because understandably insurers want to have a more attractive product, an easier to market product. And again, studies suggest a lot of those rebate dollars do go into premium declines. That just doesn't help you much if you have a chronic condition and you are going to the pharmacy every week or every month for a prescription. You don't get much peace of mind knowing that, hey, at least my premium is 10 cents less than it would be otherwise, and my neighbor down the street who doesn't have chronic conditions benefits from that too. I think what we tried to do with our legislation was say, for a subset of chronic conditions, if as a plan you are going to charge this coinsurance, you're going to charge a percentage of this list sticker price, then you got to do that incorporating most of the discounts and rebates that you expect to get on that unit. We gave them some flexibility. We actually worked really actively with some good faith folks across the sector and tried to figure out how can we set this up in a way that it was almost like a pilot program to ensure we were providing relief for patients with chronic conditions at the pharmacy counter. And I think our hope is if that provision were enacted and it works the way we think it will, and it works the way it has in states that have adopted that model for their fully insured commercial markets, my hope is that we could see that become the norm across the broader system. Again, it's a starting point. I'd love to see some of this done through regulation. I think it's been encouraging to hear some comments from Administrator Oz and others in the administration saying, they don't like the way this current rebate system functions. They'd like to see this shift. And I think for the average pharmacist, I can't imagine anyone wants to see a patient with whom they have, an operating relationship and a rapport come in to fill a prescription, find that they're charged $500 this year when last year it was $20 copay, and then have to say, I can't afford this right now and walk away. That's really bad for the patient.
Happens, right?
100%.
Yeah.
Totally.
So, again, a lot to unpack there. I think I want to make sort of 2 points and throw it back at you. I think that I love the point you made about the deductible, first of all, right? Like obviously things are moving towards co-insurance, but when you're in that deductible phase, and obviously you were talking about the GAO where like 79 of the 100 most rebated drugs, the beneficiary is actually paying more. You also touched on the fact that there are certain cases where the prescription drug plan and the PBM, who are often affiliated, are making money on that, right? In the deductible phase, if they're not, if the patient's paying 100% of that drug cost and the PBM is mandated a brand, so the beneficiary is paying more out of pocket when, let's say, there's a less expensive generic, and then on top of that, the prescription drug plan and the PBM are getting that rebate back. This is a situation where the beneficiary is paying more out of pocket so that the PBM and the prescription drug plan can literally make money, right? So really, really warped from an insurance perspective. And you also touched on premiums, and obviously sort of the concept of insurance is really subsidizing for the sickest, right? That's sort of the base. And what we have now in Part D, and also a lot of commercial plans, is, and you said perverse incentives, is a situation where the sick are subsidizing lower premiums, presumably for the many. But I want to talk about the lower premiums because I think certainly some of those, certainly lower premiums are being subsidized through rebates to a point. But what doesn't, to me, get talked about a lot is how much of those how much of those rebates are actually going used to subsidize lower premiums. And I would posit, and I'm happy to push back on this, that there's not a whole lot out there on that front. And I remember like there was a MedPAC report that estimated like $6 per member per month lower premiums over a period of, I'm not going to be exact, but let's say like 2017 to 2021, something like that. But if you take a $6 per month premium, you multiply it times all the beneficiaries in Part D, right? And then you look at just in 2021 alone, $50 billion in rebates. Those rebate dollars are not just going to lower premiums, right? I mean, they're definitely, from my perspective, that money is going elsewhere and large swaths and chunks of it. I know you've looked at this closer than probably about anybody. What are your thoughts on that?
Yeah, Greg, it's a great question. And I think what your last point is so important. And it underscores, I think, the reason why the push for transparency remains so central to this conversation and so central to a lot of legislative efforts at the federal and the state level. I think it's fair to say there are so many questions that we don't know the answer to because, again, these models shift over time, right? I think it's fair to say the rebate conversation was a different discussion in 2017 and 2018 and 19 when the first Trump administration issued and proposed the rebate rule. It was a very different model and discussion then than it is now. And I think it's fair to say, profit drivers shift. One thing you mentioned earlier, Greg, was specialty pharmacy and the specialty dispensing channel. I think Adam Fine and his Drug Channel Institute blog noted recently that I can't even remember how many years in a row it is, but based on the data, we are seeing huge growth in the specialty pharmacy channel. And again, as we both know really well, and as the average pharmacist knows really well, what a specialty quote unquote drug is in the eye of the beholder. And generally speaking, the beholder is the PBM.
Yes.
So the reality is, this channel growth, I think some of it's organic just because we have seen a lot of breakthrough specialty products. I think about oral oncology drugs come to market. But part of this, I think, is also a category question. And the reality is at this point, and again, Drug Channels broke down the top 15 specialty pharmacies by their share of prescription revenues associated with, PBM designated specialty drugs. 2/3 of that volume was affiliated with specialty pharmacies that are PBM affiliates.
Yes.
And so again, if you're the PBM and you're crafting pharmacy networks and you get to decide to some extent what type of a pharmacy can dispense a quote unquote specialty drug and what can't. You get to say, oh, this generic drug that's been on the market for years, retail pharmacies have had no trouble dispensing it in the past, but now it is a specialty generic drug.
Yeah.
And so now it has to go through the specialty channel. And there are all sorts of contracting mechanisms that any organization can leverage in order to steer volume towards those specialty pharmacy affiliates. Again, that 2/3 volume isn't just a throwaway number. It translates into the fact that now specialty pharmacy dispensing revenue accounts for, I want to say, roughly 1/3 of gross profits for PBM organizations. So I'm talking about the broader companies there. Again, that's a significant shift from where we were 10 years ago. I also look at a phenomenon like private labeling. The reality is different forms of private labeling have been around for a while, but I remember a time a few years ago when we were all pushing for more biosimilar dispensing. We had these products with, 85% discounts relative to more expensive biologics. These are essentially just complex drugs, often injectables, infusion drugs. And there was this massive push. And I think the response we saw is each of the three PBMs now operates a private labeler. So you've got Qualent, which has been around a little bit longer. You've got Cordavis with the CVS Health umbrella. And then you've got Nuvela under the UHG umbrella. And these are organizations that I think their value proposition to the public and to consumers is, hey, look, we are giving you the low-cost biosimilar access you wanted by essentially having various biosimilar companies bid for the right to sort of operate and have their drugs manufactured and distributed under these PBM affiliated labels. And look, I'm not an attorney and I don't have access to those contracts. I've not seen their books, but I think that's an area where I now see policymakers, Senator Langford, Senator Wyden, various folks in the House of Representatives asking questions about, okay, what are the margins there? What are the fee arrangements there? And again, this is not opining on whether that is a good thing or a bad thing. It's more underscoring the fact that with respect to rebate breakdowns, with respect to specialty pharmacy margins and spread and dispensing volume, with respect to new entities like private labeling entities, folks realistically and reasonably want additional transparency. And I think the patchwork of state provisions that we've seen makes so much sense from a state lawmaker perspective because they see a void, they want to fill this void. But I think especially as we've seen the courts turn away from the ruling we saw in Rutledge, where they said, look, ERISA preemption does not necessarily preempt a state from PBM-focused regulations. In other cases, more recently, we've seen pushback to that approach. And I think it underscores the fact that the feds have a valid and vital role to play in saying, okay, let's bring some transparency to the ERISA market where there's broad federal preemption and to Medicare Part D and to Medicaid. So again, I would love to know the answers to all these questions. I think policymakers and regulators would as well. And I think employers in the commercial market would love these answers. So I'm really hopeful we'll make progress there.
Yeah, so interesting. And, you mentioned private label. I want to give a shout out. I don't know if you've seen this. I'm glad you brought it up. But 46 Brooklyn had a really, really amazing piece on that. I think about 2 weeks ago that I would definitely point to and have folks go ahead and read that. So, one of the things that I don't want to, there's so many things for us to talk about here, but I think, and I'm going to push back. I don't even know if it's pushback, right? But we talked about the moving to the specialty channels and the accounting for revenue. And what I would say is they're in certain areas, as we're able to look under the rocks, sort of the data, there's already data there telling a lot of these stories, right? And so, and again, right, sometimes it's Medicare data, sometimes it's Medicaid. Sometimes you can get access to federal employee health plan data. There are 2 states that require commercial data reporting. Georgia was the first to do it in 2020. West Virginia followed quickly, and PBMs have to report certain percentages above NADAC and whether it was an affiliate pharmacy, not affiliate pharmacy. And what we see is not only do we see more and more specialty medications being, contrary to what they've said in hearings, being steered to their affiliated pharmacies in a variety of ways, including contracting, including plan design. But what we know is that oftentimes these are not savings, right? When you compare the markups at the affiliated pharmacies to when independent or even non-affiliated retail pharmacies are able to fill these drugs, you're seeing massive markups. And so I certainly think transparency is a really good thing. I would say in certain markets, we've seen enough to know that action needs to be taken. And it's interesting because I definitely hear you on the patchwork it states, but I'd also posit, and this is a guy who came from a state background, right? But if it weren't for the states, God help us right now, PBMs would have the run of the house because federal laws have not even remotely kept pace. And there's reasons for that. And I want to talk about those reasons, right? It's harder to move stuff at the federal level. So I'm going to ask you that, but also in the context of Trump is back in office. And, he was willing to really go beyond just transparency with sweeping safe harbor reforms to ensure that beneficiaries get the benefit of that discount. I was a big fan of that, right? I make no apologies for that. The Inflation Reduction Act certainly, undermined that by pushing implementation back to 2032. With Trump back in office and a HHS and a CMS that is looking, I think, to take big swings, and you see with the most favored nations, would love you to talk about why it's more difficult, why we don't see more aggressive, meaningful, comprehensive reform that's passed at the federal level already. But also, does President Trump being back in office and with these new sort of agency heads, is there an opportunity for more sweeping material change as well?
Yeah, Greg, it's a terrific question. I will say at the outset, one of the most important points you just made, and it's one that we made again and again in discussions with our members, and I think there's broad bipartisan and bicameral support for this premise. We've got to go beyond transparency, particularly in markets where we've seen enough. I think the biggest example of that is probably Medicare Part D and Medicaid. And I think what you've seen is not just the Senate Finance Committee, but also multiple different House committees have in the past couple of years advanced reforms that are aimed at, for instance, in Medicare Part D, delinking PBM compensation in that market from the prices of drugs. Because again, if you have a system where I'm the price negotiator and I get paid 30% of whatever the price is, it doesn't take a genius or a rocket scientist to recognize that's creating an incentive for me to preference drugs with higher prices. And to your point, the Office of the Inspector General and the GAO have produced ample data demonstrating in living color the fact that we have seen distorted preferencing. And by the way, GAO's 2023 report, in addition to talking about the rebate distortions as a matter of cost, they looked at some of the contracting arrangements, and in most cases, you saw examples of deals between branded manufacturers and PBMs that would say, I will pay you a bigger rebate if I'm the only drug on this tier, or if I'm the only drug on formulary, or you keep generic or biosimilars off. I don't say that with any disrespect or disdain for the folks at that contracting table. They're responding to the incentives within the program as it exists now and the law as it's been interpreted now. But I also think we can look at that and say that's a problem, right? That's a problem for consumers and it's a problem for the market. So to my mind, Medicare Part D delinking, I think, is a terrific first foundational step. And my hope is that as we take that step, as we also, again, through some of the reforms that we saw multiple committees across both chambers advance on a unanimous basis, as we give some teeth and put some meat on the bones of any willing pharmacy protections. The laws right now say that the terms and conditions that are offered by a plan or PBM to pharmacies are supposed to be quote unquote reasonable and relevant, but that's not been fleshed out. I think
partially because the non-interference clause too, right? Like it's very difficult.
Totally. And that's why I don't say any of this diminutively towards CMS either. I think that the sense from the agency is Congress needs to step up and give them some direction on how they want this to look. And again, I actually have a relatively high level of confidence that Congress will advance those pharmacy access protections in Part D, that they will move Part D PBM fee compensation delinking, that they will prohibit spread pricing in Medicaid, another area where we've seen copious data, also not just from the feds, but from folks like Antonio, as you mentioned, who's been living and breathing this stuff long before the public knew what a PBM was, and who's kept pace with terrific research. And so, again, I think with respect to federal policy, there is a consensus among most members in both chambers. And I've seen Speaker Johnson talk about this. I've certainly seen Senator Thune, the majority leader of the Senate, talk about this. And in fact, he had provisions included in the Finance Committee's package that he voted to advance. So I think where there's a real path forward on Capitol Hill right now is with respect to those provisions that are focused on Medicare and Medicaid. And I think commercial market transparency, because I do think there's a consensus in both chambers. And the Congressional Budget Office, by the way, says all of this will save money for the taxpayers, for employers, and for employees. Folks want to look under the hood. So those areas, I think it's a question of when is Capitol Hill going to find their next opportunity for a bipartisan vehicle? Look, we had fits and starts when I was on the Hill. It was never reasons related to healthcare provisions specifically. It was broader macro politics. I think it's a question of when, not if, for those policies to move. I think where Congress has been the most reluctant, and Greg, this speaks to your question around some of the difficulties from a federal policymaking standpoint. Yeah. There is a real apprehension on Capitol Hill, particularly among many Republican members, around interventions into the commercial health insurance market. And I think some of this is born out of the Affordable Care Act, where a lot of folks did see premium hikes in the early years. And again, I think the general public early on, there was some backlash. I think increasingly the general public has said, the growing pains are behind us. This was, legislation that love it or hate it. It's the law of the land now. But I do think there's a knee-jerk fear and apprehension and skepticism. And what I would advise for folks on listening to this podcast who are interested in how to advocate effectively and how to try to push for federal reform, I think showing examples of how state laws have played out in practice. I look at the example of rebate reform.
West Virginia.
Reflecting rebates at the point of sale has worked across multiple states, has not led to premium hikes. We'll see what Colorado's experience with PBM fee delinking looks like. But again, if that's successful, I think that creates a really strong case to Capitol Hill that, look, these are smart market-oriented interventions into a market that is not functioning in accordance with quote-unquote market economic principles because there's concentration, there's information asymmetry. So I think congressionally, there's definitely going to be an appetite for movement, and I think folks recognize there's a need for policy. But I would expect more movement on the Medicare and Medicaid side and a little more apprehension on the commercial side. With respect to the administration, just to quickly get to the second part of your question, which is a great one, I think if you look at remarks from the president, he clearly wants to revisit this issue. PBM reform, again, was a key focal point under the first Trump administration. I think right now a lot of the energy appears to be around this most favored nation concept. Just speaking on my own behalf, I think that's a fraught concept. I think it has all sorts of operational concerns. I think the other piece, though, is our pricing system stems in part from this opaque patchwork of different rebates and discounts and various different pressures. It's not transparent. I applaud the administration for pushing for additional transparency in this space from a regulatory standpoint. It seems like that's their first step. But my hope is that this most favored nation concept, that as the administration considers it, some of these challenges will come top of mind. And I think that the reality of a very high risk of a legal litigation boondoggle with no actual policy effect, and of a conversation shifting away from the American system and how to improve it and shifting towards various European systems, that I think for many Americans, they wouldn't want the National Health Service. I don't begrudge my British friends. They're very proud of that system, but that's not what Americans have signed up for. And so
they're also very uptight, the British. I think we can agree on that. Is that fair
without commenting on the UK or the Brits, all I would say is I think for the average American, there's a lot of appeal to prescription drug affordability. And
Absolutely.
My hope is that we will see a pivot away from MFN and towards more aggressive, assertive action on issues in areas like this, where, again, Dr. Oz, his remarks at the Transparency is Rising conference recently, I think it suggested to me he understands these issues inside and out, and he understands this market. And I applaud the administration for its efforts towards collaborative, cooperative policymaking in a number of areas. My sincere hope, as someone who has a long-standing interest in seeing PBM reform happen, and I think that requires both regulatory and legislative action. My sincere hope is, if we don't see significant market-driven shifts on a voluntary basis, and I haven't seen them to date, as we have in some other markets, then I have my hope is that Administrator Oz and HHS Secretary Kennedy and President Trump, all of whom have expressed interest in pursuing smart PBM reforms, my hope is that this could become a regulatory agenda item. It feels like this year has been, lengthy in some ways, lots of policy activity, but we're still in early innings with respect to the broader term. I think back to Trump 1, a lot of the policy action on a regulatory front with respect to healthcare didn't come until 2018 or 2019.
Yeah,
so I would encourage folks not to lose hope.
Yeah, and even with the safe harbor reform, right? That's something that he sort of planted a flag very early, but the actual regulatory came very late in the term.
Exactly.
So that's a great point. Okay, we don't have a ton of time left, so I want to try to address three things really quickly. And I love that you touched on the state data. You also mentioned Congressional Budget Office and savings. One of the things, and you can disagree with this, but one of the things that I find is that independent pharmacists have great relationships with their Congress people, and they do a great job of explaining the issues. And there's a will to affect really significant, meaningful change. And some of that butts up, and including what President Trump tried to do with rebates, butts up against problematic Congressional Budget Office scoring. And so often, to me, it seems like these are based between a Congressional Budget Office and also some staffers on the Hill, right? These issues have been hammered by insurers and PBMs and interests for a long, long time. And it seems to me there's very much presumptions that, oh my God, if you touch rebates, premiums rise, or if we're not the ones setting the prices, or if we're not able to steer, premiums and costs rise. But the data tells a really different story, and you touched on that, right? So very recently, the West Virginia rebate pass-through law, which basically says, hey, you have to share the discount with the patient, and anything left over goes to lower premiums. And the insurer's own data that they submitted, their actuaries that they submitted to the Commissioner of Insurance, showed that ended up reducing premium growth anywhere from like 1 to, don't quote me, but 11 or 12%. In Georgia this year, there was a repricing, PBM pricing for 2023 versus moving to an index plus model, right? And lo and behold, guess what? When they did actual repricing and there wasn't a presumption, there was $11 million in savings, conservatively, based on that repricing. And so I know, like, there were times, I don't want to put words in your mouth, where I'm sure, like, you all wanted to even be more aggressive in certain ways, right? But you've got this you've got these realities, and what can be done, and do you think data-driven advocacy can help shape that? And then part two to that is give our listeners a little idea of just how, like, look, you were in the pit, you were shaping the policy, how engaged and how many insurer and PBM interests are involved in this process as well.
Yeah, Greg, it's a terrific question. I will say, anytime to start with the latter piece first. Yeah. And I'll be brief in these responses because I've not been brief enough so far. But I think it's fair to say, with respect to any healthcare policy, because the federal government accounts for such a large share of the healthcare market,
massive,
and that's truer of healthcare than I think virtually any other sector of the economy. Possible exception of agriculture, but I think healthcare might have them beat. The reality is, folks have a significant amount of money on the line, and that's true for any stakeholder. So I think it's fair to say, as we went through the process, Polly and I undertook a series of listening sessions and meetings with every stakeholder group under the sun. We talked to large PBMs, small PBMs. We talked to community health plans and larger insurers. We talked to patient advocacy groups. And I think the reality is it was a diverse landscape of perspectives. And look, I think the folks who felt that they had the most to lose under the policies that we were proposing, they did their constitutional right, and they were extremely vocal. And again, that's going to happen with any process. But I think it's also fair to say, with respect to the Hill's response, I think the advocacy from community pharmacies and from a lot of small businesses, like I think about some of the small and mid-sized PBMs, inclusive, and I think about some of the smaller insurers, I think offices were really receptive to those messages because those folks serve the residents of their states and their districts. And I think, candidly, there was so much lobbying from all directions on this front that it made for better policy. I think Polly and I were much more rigorous in terms of, the microscope we would expose every provision we wrote to, because we knew that a lot of vested interests cared very passionately and we're going to be talking to our offices. And we wanted to make sure that we could justify all of the provisions and really incorporate member perspectives. So it's always going to be fraught with healthcare. I will never begrudge anyone for, conveying their interests, but this was probably one of the most frenzied experiences in terms of lobbying activity on the Hill. With the Congressional Budget Office piece, I'm very optimistic on this. I found that when we worked with CBO, they're really good, hardworking people over at CBO. And I think, there's this imagined universe sometimes where we picture like hundreds of thousands of CBO analysts working on any given project. The reality is Congress does not fund CBO to that level. And so oftentimes you've got you've got a few folks who are working on massive portfolios. What I found is CBO was incredibly receptive to, we would send them reports, studies. Greg, you guys were extremely helpful to us in terms of, giving us access to, hey, here is a state level report you guys might have missed. By and large, the federal government, could afford to spend more time looking at state level information. And so, again, I think we really took seriously when CBO said, we want to see more research, we want to see evidence, we want to talk to folks. And it was telling to me that when CBO scored Part D PBM compensation delinking, but also the commercial market PBM delinking, they scored those as reducing the deficit in both cases by really substantial amounts. I think it suggested a really thoughtful process on their part and a real open-mindedness, because it was a policy they hadn't been asked to score in the past. With issues like rebates, what it suggests to me is you've got folks at the Congressional Budget Office with an open mind, and I think these guys love data, and they love hearing from folks with, hey, here's our perspective. That doesn't mean that they're going to agree with all of it or that they're going to look at any study, with eyes closed and say, oh, I'm sure these findings are perfect. But I think there is a real opportunity for folks across the healthcare sector to leverage some of this state data to help assist, again, folks at CBO and folks on Capitol Hill with understanding how these complex policies play out in practice. And again, I think we had a really positive experience in that context. You're right. With the rebate rule, I think the scores were inflated. But I would also say CBO and the Office of the Actuary at CMS, they had much less experiential real-world data.
It's a different time. Yeah, it's a different time.
Exactly.
And times
Things have
change and data evolves. You mentioned Polly a lot. So, and I think we touched on this, but just for listeners, right? Polly was your Democrat counterpart on Senate Finance Committee. And one of the cool things, I think it'd be great just for listeners and pharmacists know this, is like how closely two of you are both two of the smartest on the Hill, probably two of the smartest in the country, not pharmacists either, right? On a lot of this stuff, but you guys worked incredibly closely on this together. You also spent a lot of time on it. Like Absolutely. A lot of time. And I think it speaks to the bipartisan nature. But I mean, like is it fair to say, and correct me if I'm wrong, but like this was a priority for you all. And it's something that really, it seemed like you all got legitimately passionate about.
You hit the nail on the head, Greg. It's by far the proudest thing I worked on Capitol Hill in my time there. And I know that the provisions have not been enacted yet, but I remain really optimistic. And again, not speaking on behalf of my firm or on any clients, but I remain optimistic they will. And I think the bipartisan work stemmed from, I think Polly and I, we took a practical, realistic approach, and we recognized that bipartisanship does, generally speaking, make for better policy. You pressure test each other's ideas. You ensure that you're bringing in a wide array of perspectives. I look at the Senate Finance Committee. On the Democrat side, you've got Senators Warren and Sanders. You've also got folks like Senator Warner. And I look at the Republican side. You've got Senator Marshall, Senator Blackburn, Senator Thune, Tillis. These are folks with a really wide range of perspectives. And I think that helped us to pressure test and inform our policymaking. And I remember when Senator Scott, when I first started working for him, he was on not just the Senate Finance Committee, but also the other key health committee, the Health Committee, the Health, Education, Labor, and Pensions. And Lamar Alexander was the chairman at the time, and Patty Murray was the ranking member. And I remember Chairman Alexander would talk across a number of hearings about the split screen of Congress, where on one side you've got a lot of the political noise and the shirts and skins partisan exercises.
That's right.
On an issue like the IRA, I was the lead GOP staffer on those drug issues. We didn't care for the bill. We fought tooth and nail, but with respect. Yeah. But that's on that side of the split screen. And again, I think cable news-wise and just news in general-wise, that's where a lot of the attention of the public is directed. The other side of that split screen, with Alexander and Murray, was the fact that they were churning out bipartisan healthcare, education, pensions bills on a weekly or monthly basis. And I think that was a tried and true model that, for me, I always suggested that bipartisanship was the secret sauce. And again, as you mentioned, Greg, PBM reform was a personal passion project for me, for Polly, and I should say for many of our colleagues across a lot of offices in both chambers who were terrific champions and collaborators. But it was a massive time commitment. I'm shocked my hair is not turned gray yet.
Hey, it's not a shot at me, Connor.
No, not at all. Not remotely, Greg. But the reality is this was, I think it was our top healthcare priority. And I think it should be encouraging for folks listening to this to know that even if the noise around Congress is devoted to other topics, which I will not touch with a 10-foot pole on any given day, the actual work getting done behind the scenes in a given week on Capitol Hill is by and large bipartisan, it's bicameral, it's thoughtful, and it's unsexy. And sometimes unsexy politics make for better policy and improve the odds that things can get done. So again, I remain an optimist at heart, and I think the experience of working on a bipart basis and seeing Senators Crapo and Wyden partner so effectively, to me, it's a really positive signal in the midst of what I know can be a really partisan political moment.
Well, I don't know that we could end it on a better note than that. We're going to have you back if you're willing, for sure, because there's just still so much to cover. I thank you, because I feel very much like you gave our listeners insights and perspectives that it's just so hard to get, right? Like it's its own thing up there. And even pharmacists who fly in and meet with their Congress people, right? Like you've given a perspective that so few have, combined with the fact that you're just so nuanced on this issue, right? I mean, I couldn't be happier with sort of the subject matter we covered. And again, there's plenty more to talk about. So thank you so much. And just appreciate you being on.
Thank you so much for the opportunity, Craig. Really appreciate it.